Thank you so much for the kind introduction, and thank you, Jeff and Jorn, for inviting me to beautiful Barcelona. I've been here a few days, and I made a point to eat paella and patatas bravas every day. So I need to go check my fiber scan when I get back to Phoenix and see how much damage I did, and maybe do some intermittent fasting to reverse it. And I think this is why knowing, what's happening in your body is very important. So the task that I was given is to talk about pharmacotherapy medications, anti-obesity medications to improve body weight in the context of NAFLD. So these are my objectives. First, I want to discuss the goals for NASH management and why we need anti-obesity medications. We call them AOMs. And then I want to discuss the available anti-obesity medications and their utility in the real world, and then describe the spectrum of weight loss approaches for the management of NASH. I'm active on Twitter. I've been tweeting all meetings, so please follow me. This is my Twitter handle. And then we also have a TikTok account. How many people here are on TikTok? Show of hand, no one? Great. Okay, well, maybe it's time to get on TikTok. There's a lot of medical stuff happening there, so this is our TikTok account. All right, so when we talk about the goals for NASH management, what are we trying to accomplish? Obviously, weight loss is very important, but as we heard earlier, NASH is a systemic disease, so we need to be looking at the entire metabolic syndrome, try to improve high triglycerides, high cholesterol, lower blood pressure. We also need to target liver outcomes and looking at NASH resolution and fibrosis regression. So when we are thinking about managing this disease, we ideally want to achieve all of this: lose weight, treat metabolic syndrome, and achieve liver outcomes. And most importantly, we want to reduce mortality, right? We don't want anyone to die from NASH. And when we look at the causes of mortality with NASH, the number one cause is cardiovascular disease. And especially when you look at non-cirrhotic patients, patients with F3 fibrosis, you see that major adverse cardiac events are a leading cause of death. And then when we look at patients with NASH cirrhosis, then you have what we call major adverse liver outcomes, or MALO. And MALO in Spanish means bad, and this is really the worst thing that can happen if you have NASH, is to develop ascites, encephalopathy, variceal bleeding. These are the major adverse liver outcomes. So in terms of weight loss through lifestyle modification, we heard from Dr. Zelborsagi that it is effective, and if you lose more than 7% of your total body weight, you might be able to achieve NASH resolution. If you lose more than 10% of your total body weight, you may achieve fibrosis regression. And this is an achievable goal, because if someone is 300 pounds, they need to lose 30 pounds. So we are not talking about normalizing your BMI. The problem is that only a minority of patients are able to achieve this. So you see in the red box, only 10% of patients that were enrolled in a clinical trial where they had visits with the dietitian on a monthly basis, they had a weekly phone call, only 10% were able to lose that 10% total body weight, and only 18% were able to lose 7%. So this is a major issue with weight loss through lifestyle modifications. How about extreme weight loss with bariatric surgery? And Jorn mentioned some of this data from France, looking at patients with NASH at the time of surgery and then liver biopsy 5 years later. And you can see NASH resolution in 85%. So bariatric surgery, if you lose a lot of weight, it's very effective. And the chances of resolving NASH go up as you lose more weight. Even more important is bariatric surgery can affect long-term outcomes. This is the study that Jorn mentioned yesterday. I want to just get a little bit deeper into the study design and what we did in this paper that we published last year in JAMA, looking at 650 patients that had biopsy at the time of bariatric surgery, and they were followed for 10 years. And instead of looking at NASH resolution and reduction in liver enzymes or liver fat, we looked at major adverse cardiovascular events and major adverse liver outcomes, because we want to look at what is killing these patients with fatty liver disease. So these are the patient characteristics. You can see that we really matched them very well in terms of age, gender. BMI was obviously higher in the patients that received metabolic surgery, but otherwise they're very similar, including the severity of disease in terms of NAFLD activity score and the fibrosis stage. And one important thing to realize in this study, we did not include patients with NASH cirrhosis, and this is where it gets tricky with bariatric surgery. So how did they do? Look at the major adverse cardiovascular endpoints, MACE. You can see clear separation with the bariatric surgery group doing much better than the non-surgical control. The hazard ratio was at 0.3, which means 70% reduction in terms of cardiovascular outcomes. And more importantly for us as hepatologists, when you look at major adverse liver outcomes, also clear separation. It didn't take a long time to see that separation, and 88% reduction in progression to cirrhosis or developing hepatic decompensation. So if you lose weight with bariatric surgery, you're going to achieve the most important thing, which is reducing mortality in patients with NASH. How does bariatric surgery work? It's really the significant weight loss that you see. So this is from the same paper. You see these patients at 10 years lost about 20% of their total body weight. So ideally, if we're going to do an intervention for weight loss, if we can achieve that 20%, now we have data showing that you can reduce cardiac outcomes and liver outcomes. And there is also significant reduction in A1C with bariatric surgery. So can we do this without surgery? So when we talk about weight loss, this is the weight loss pyramid. We have, lifestyle interventions, diet, exercise, cognitive behavioral therapy. Everyone should receive these. The tip of the iceberg is bariatric surgery, but only about 2% of patients that qualify for bariatric surgery in the US end up actually getting the surgery. And in between, we have medications, anti-obesity medications, pharmacotherapy. So what are the AOMs available to us today? In the United States, we have 6 of them. Orlistat, phentermine. We have phentermine in combination with topiramate, naltrexone, bupropion, and then 2 GLP-1 agonists, liraglutide and semaglutide. And you can see the availability in other parts of the world. The problem with the oral medications, the first 4, that weight loss is very modest, so 3 to 5%, and they do have side effects, including potentially increasing blood pressure, arrhythmias, anxiety, so they don't come at a cheap price, and the uptake has been very low in the United States. And then we have the GLP-1 agonists. These are injectables, and they are costly. In terms of the effects of anti-obesity medicines on NAFLD-NASH, this was a systematic review published in 2020, and they divided the benefits into histologic benefits, reduction in inflammation and liver fibrosis, and then reduction in liver fat, and then improvement in serum biomarkers like ALT and AST. And if we focus on the histologic benefits, you can see that there is limited data with all of these medications, and many of them really have no data, including some of the newer diabetes medicines. The data is being generated now, like SGLT2 inhibitors. Here it was insufficient data with GLP-1 agonists, but we have the paper now with semaglutide, so we definitely have more data. But one thing that we lack is that we don't have any convincing data on fibrosis regression with anti-obesity medicines. Even with semaglutide in the phase 2b trial, there was resolution of NASH in almost 60%, but there was no effect on fibrosis regression. So this is something that we would like to see. So this is an algorithm how you can incorporate these anti-obesity medicines in the management of NAFLD. If you have someone with NAFLD BMI less than 35 without diabetes, okay, fine, start with lifestyle modifications. If you're not succeeding, you can add medicine. But if you have someone with the BMI above 35, or if they have type 2 diabetes, we need to think about incorporating these anti-obesity medicines early on, so we can achieve that desired threshold of weight loss. And then if you do this in conjunction with lifestyle and you are not succeeding, then maybe it's time to talk about bariatric surgery or even some of the endobariatric procedures that Jorn mentioned yesterday. So how well do we do with these anti-obesity medicines in the real world? This is from a large cohort within a claims database called Truven Healthcare. They have over 100 million lives in it, and they looked at all the patients that were prescribed anti-obesity medications. And you can see the different medicines that were prescribed. The first one is lorcaserin, which is no longer available, but you see liraglutide, you see naltrexone, bupropion, and phentermine, topiramate. And this was a large cohort, almost 26,000 individuals that were included. And you can see actually the age and gender, but also look at the region in the United States, and you can see that we prescribe more anti-obesity medicines in the South, where we have a bigger obesity epidemic. So how well did they adhere to these anti-obesity medicines? This is what you see in this figure here. You can see a huge drop. I mean, everyone was prescribed these medicines at baseline. And then you can see within the first month, many of these patients did not even fill one prescription. If they filled one, then they didn't do any refills on it. And you can see significant drop by 6 months. If you follow them to 15 months, with all the medicines, the adherence was less than 10%, except for liraglutide, okay? And liraglutide is the only injectable one. So you would think, you know, they'll have less adherence, but the hypothesis is that patients were losing more weight and they saw more benefits, so they adhere to it. But even with this, it was only 26% that continued to refill the medicine. So this is the problem that we have with anti-obesity medicines, that they might be effective, but in the real world, patients are not adhering to them. How about the new version of liraglutide, semaglutide? This is data from the STEP 1 trial. This was a large study, almost 2,000 patients for 68 weeks treated with the high-dose semaglutide, 2.4 milligrams weekly. You can see the eligibility criteria. These were non-diabetic patients. And basically, these are the results. So you can see in-trial data, and you can see on-treatment data. So the way I think about it, this is kind of like intent-to-treat analysis. This is per protocol analysis. And there was significant and sustainable weight loss, almost in the 16-17% total body weight loss at 68 weeks. So this is really important, and I think this is encouraging that we can achieve this weight loss with a medicine that you inject once a week. And then if you look at the different thresholds that we are trying to achieve, let's say the 10%, well, almost 70% who received semaglutide were able to reduce their total body weight by 10%. And this is the threshold associated with NASH resolution and potentially fibrosis improvement. Even when you look at reducing total body weight by 20% or more, 1/3 of patients achieved this. And you can see in the placebo arm, the percentages were much lower. So this is very encouraging. We also have cardiovascular outcome data with semaglutide. This is in a diabetes population. This is the SUSTAIN 6 trial looking at cardiovascular outcomes, and you can see clear separation with semaglutide. And also there's definitely a decrease in hemoglobin and body weight. And the decrease in body weight was a little bit less than the STEP 1 study because this is the diabetes dose of semaglutide, so we go up to 1 milligram weekly. But this is very important in the context of NASH, that now we have cardiovascular outcome data with semaglutide, and cardiovascular disease is the #1 killer in patients with NASH. They actually have a follow-up study called the SELECT trial that recruited 17,000 patients without diabetes, and they're looking at cardiovascular outcomes. So be on the lookout for that trial. The results should be published before the end of this year. And more recently, tirzepatide also showed very promising data in terms of weight loss. So this is data from the SURMOUNT-1 trial. It's not peer-reviewed yet, so I want to caution you, but they had tirzepatide with 3 different doses, and with the highest dose, patients lost 22% of their total body weight. So this is very encouraging. So based on this, you can say, okay, we found the solution. We don't need to do bariatric surgery. Lifestyle is great, but it should be in conjunction with this. Let's just get everyone on GLP-1 agonist or dual agonist. But obesity is complicated, and the story is not over. So this is data from the extension arm of the STEP 1 trial, okay? So they did the 68 weeks that I showed you, and then they had 327 participants that just continued on discontinued semaglutide, and then they're followed for 1 year after they stopped semaglutide. And the purpose of this was to look at weight regain after we stopped semaglutide. So what happened to these patients? And this is what happened. They lost the initial, 17% of their total body weight, and then they stopped. And you can see 1 year after they stopped, they regained 2/3 of the weight that they lost. So when it's all said and done, after 1 year of semaglutide and then stopping 1 year, they lost about 5% of their total body weight. So this is important because we really don't know. I mean, is it going to be something we use for a couple of years and then the patients are able to maintain that weight loss, or they're going to regain it back and then we're going to look, 5 years later and feel like we spent all this money and we're still where we started. So this is very important. And the same story is showing up with A1C rebounding also. Even if you look at their blood pressure, it goes up after you stop semaglutide. So the story is far from being over in terms of managing obesity and getting to that sustained weight loss. So I think these great weight loss medicines need a little bit of hand-holding and maybe other ways to maintain that weight loss that will not depend on being on the drug for the rest of your life, especially for young patients. Think about it. If you have an obese patient who's 30 years old with fatty liver disease and very high BMI, and you get them on semaglutide, for how long you're going to keep them on it? For the next 60 years to maintain their weight? I don't think this is cost-effective. So how can we sustain that weight loss without medications? This is where I see an opportunity, although we need more data, for what we call prescription digital therapeutics. So these are apps that will actually meet the criteria for FDA approval in the United States, and they will require prescription by a healthcare provider. And maybe with less severe obesity, they can be sufficient to induce weight loss, but I see them also as something we use in combination with weight loss medications. So not all apps are created equal. So there are apps that target just general health, like MyFitnessPal, which I use personally, or Calm for meditation. There are apps that have specific indications, like the Noom app, where you're targeting weight loss, but this does not have an FDA indication, and you do not need a prescription. You just need to subscribe to it. And there's the last category, which is the prescription digital therapeutics. And one company we're working with now is called Better Therapeutics, and this was mentioned in an earlier talk, where they try to rely on the concept of nutritional cognitive behavioral therapy, and they utilize plant-based meal planning for the most part. So we need more data, but I think there's an opportunity to combine these prescription digital therapeutics with medications. And this is from a press release from Better Therapeutics, where they actually conducted a randomized controlled trial with their app called BT001 and a sham app that doesn't utilize the same concepts. And this was a large study for a digital therapeutic company, 669 patients with type 2 diabetes. They are randomized to the two arms and followed for 6 months. And the primary endpoint was change in A1C. And they showed that reduction of A1C by 0.4% or more occurred in 42% in patients in the app plus standard of care versus only 25% with standard of care alone. And this was statistically significant. Moreover, they can look at the engagement with the app and how many minutes each patient spent on the app, and they found a dose-dependent correlation. So the more engaged you are with the app, the A1C dropped further. So this is very promising. So this is the weight management spectrum for NAFLD as I see it. We need to start with lifestyle interventions always, but now we have prescription digital therapeutics and other apps. We have anti-obesity medicines that are oral or injectables. We have endobariatrics and we have bariatric surgery. And we need to consider all these options and not limit our patients to one approach or one intervention. And finally, I want to leave you with a couple of slides on how we need to assess the new NASH drugs and how important it is to think of NASH as a systemic disease and not just as a liver disease. So as hepatologists, we are so liver-centric. When we look at new drugs, we're always looking at liver outcomes. What's the percentage of NASH resolution, fibrosis improvement, reduction in liver fat, liver enzymes. But every drug we evaluate, we need to look at the effects of metabolic syndrome. Is this drug causing weight loss, or maybe it's causing weight gain? And that's a big deal that we need to be aware of. Is it causing dyslipidemia, or it's improving dyslipidemia? And we have some NASH drugs that can actually worsen your LDL cholesterol, which is the last thing we want. So this is very important. What's the effect on insulin resistance, and what are the side effects of the specific drug? And this is how we utilize this NASH score card to evaluate different drugs. Here I'm listing a few drugs in phase 3 trials in terms of the liver outcomes, the metabolic syndrome outcomes, and adverse events. So this is my take-home message slide. I think currently available oral anti-obesity medicines have low efficacy and adherence, so that limits their real-world use in patients with NASH. I think GLP-1 agonists and the newer dual agonists are very promising, but I showed you the data on weight regain, so this is a major problem, and we need maybe prescription digital therapeutics or other interventions in combination with these anti-obesity medicines to provide the tools to maintain the initial weight loss. And finally, I made this for Stephen Harrison. I thought he's going to be here. This is the Texas food pyramid. I lived in San Antonio for 3 years, and you can see we start with pie and ice cream all the way to barbecue and steak, and this is the uphill battle that we are dealing with every day. So it takes all of us to combat this disease. Thank you for your attention.